Without further ado, I want to tell you that this month's speaker is about the pharmacy industry and compounding medications, because when I mentioned that 1 month before, I got a lot of blank stares. People weren't familiar with what that meant. So I have Franco Franca from Dollar Drug. He's a registered pharmacist, and he has a presentation for you.
Can everyone hear me okay? All right, so I wanted to start off by thanking Kira for reaching out to us at Dollar and making all of this happen. But I also want to thank all of you for your time and attention. I very much appreciate that on this rainy day. So I was asked to give a bit of a discussion on what compounding is and how it relates to the geriatric population. But before I get started, I did want to mention that I got my first exposure to healthcare actually growing up in a senior care facility. I don't know if anyone in the crowd has ever heard of a place called Indian Valley View Senior Home in Novato. My mother ran that for 15, 20 years. So that was my first exposure to healthcare. So it's kind of very full circle to be here today speaking to a group that she may have one day participated in. Anyhow, thank you, and we'll move on. I'm Franco, pharmacist at Dollar Drug, and I just want to recognize initially that a lot of people understand compounding to be what this cartoon illustrates. I had a discussion with Bob earlier this morning, our resident audiovisual specialist, and he mentioned himself that he had understood that it was the compounding of many medications into one formulation. So this cartoon kind of illustrates that, but really there's a lot more to it, and hopefully by the end of our discussion you'll have a good sense of that. So I wanted you to know a little bit of my background and where I get my experience about compounding. So if you dial back the clock to 2008, I was attending UC Davis and had almost no idea of what compounding was. I got my experience shortly thereafter when I matriculated to UCSF, and at that point I had taken a few courses in compounding, gotten some exposure in the classroom setting, and then subsequently moved on to obtain a position, a paid position at the UCSF Medical Center as an intern, also a technician. In that setting, I worked in their non-sterile compounding pharmacy at the hospital and made many preparations for their pediatric population, and then subsequently moved on to their sterile compounding center, which in that setting I was fully gowned up with gloves on, working in a sterile hood in a negative pressure room like you might see in a movie. It was pretty exciting, but after a while, the 2 a.m. chemotherapy compounding sessions wore on me a bit. So when I completed my 1,500 hours of experience working there that I needed to sit for the Board of Pharmacy exam, I then moved on to completing my degree at UCSF, which also involved several 6-week experiential learning blocks. The last year of pharmacy school is much like a doctor would experience experiential learning. One of those 6-week rotations was in a compounding pharmacy, so I was fortunate to have that exposure as well. I then went on to graduate and work at Dollar Drug as a graduate intern pharmacist. As you know, Dollar Drug is a compounding pharmacy, so I got great exposure in that setting as well. I've been there ever since. After passing the Board of Pharmacy exam, I was hired on as a compounding pharmacist, where we work with Memorial, Sutter, and Heartland hospices closely. I heard that there's other hospices in the room, St. Joseph's and Hospice by the Bay. I'm sure we'd be happy to work with you as well. But and again, very interesting being able to come up with creative compounding solutions to issues that they encounter in those settings. I've also been fortunate enough to go to many different compounding symposiums over the years, ranging from bioidentical hormone replacement therapy to wound care and scar healing. So a very interesting experience that I've had so far. So I call this slide Preaching to the Choir because I know you know that what you do is important, but I just wanted to mention a few things I noticed in my research for this discussion regarding our particular population of aging adults. The middle quote there kind of really struck me when I was looking at the state of aging and health in America. It's a publication put out by the CDC. It mentioned that every day since January 1st, 2011, 10,000 American residents hit the age of 65, and that's going to continue clear through 2030. And when that is complete and the last baby boomer hits that age, it's going to be 1 in 5 Americans that is considered senior citizens. So that's a huge patient population. And so I just wanted to thank you for all the work that you do and let you know that we appreciate in pharmacy as well how important this is. And hopefully by the end of the day, you'll have a little bit of information you can take back to your practice with you to better serve this population. So I wanted to ask you a couple of questions here so that I can frame our discussion. And if you wouldn't mind raising your hands, especially if you feel comfortable doing so. I don't want to violate anybody's HIPAA rights. But first off, who's ever used a compounded medication themselves? And please keep your hands up as we go through. Next, who's known someone directly who's used a compounded medication? Okay. Finally, who's had some level of exposure to the term compounding before today's discussion? Okay, so most of the room. Wonderful. So that helps me understand how to frame things here. So some of the learning objectives for today, hopefully by the end of the day, we can all describe what compounding means. Understand the different kinds of compounding that are available out there, what kind of conditions they can be used to treat, when it's appropriate to use a compounded medication versus using standard therapies that are commercially available, and to understand how these treatments relate to caring for the elderly, as well as being familiar with common formulations that are available. So what is compounding? I went on the Professional Compounding Centers of America's website to kind of see if there's a formal definition in the world of pharmacy for this, and there is. You can read it here. And by the time I was done reading it, I was out of breath and sort of confused, even though I'm a compounding pharmacist myself. So I thought, what is this really trying to say? And there's really 5 necessary components here, and it's the patient, the doctor, and the pharmacist working together to come up with a solution for a particular problem. And that solution is a compounded medication that's made in-house at a local pharmacy. So patient, pharmacist, doctor, problem, medication. So an overview of the different types of compounding. There's sterile compounding, which is what I discussed. Oftentimes this is used for chemotherapy. This can be beneficial in many different aspects, or in many different ways, particularly in the way of compounding multiple chemotherapeutic agents into one sterile preparation. This is convenient on many different levels. It prevents the patient from having to come back to the hospital or to the infusion center for additional therapies. It decreases the amount of office visits that they have to do, which decreases the time the doctor has to put in, which decreases the cost of therapy. So very beneficial. You also see sterile compounding with injections that can be oftentimes given as epidurals. You may have heard of the New England Compounding Center's scare and so forth. Those were contaminated epidurals, but that is an example of how sterile compounding is used. Non-sterile compounding is pretty much everything else except for nuclear pharmacy, which we'll get into in a moment. Non-sterile compounding encompasses everything from making veterinary medications, a human formulation, into something that's tuna fish flavored and a chew tab for Fido, to bioidentical hormone replacement therapies that can be targeted hormone regimens that are applied transdermally. So it's a very broad field of compounding and very all-encompassing. So nuclear pharmacy, on the other hand, is very, very, very specific, a very small slice of the compounding pie. This is most often used for imaging procedures. Usually pharmacies will have an in-house cyclotron or a device to create radioactive isotopes that they'll then make into a sterile preparation for injecting into a patient so that they can have, for example, a PET scan or some form of imaging procedure done in a hospital. Other times it's also used for certain types of radiation therapies. They're used intravenously, but very, very specific type of pharmacy. So I thought about the pros and the cons of compounding, and I wanted to give you a taste of that. But first I wanted to start with the sort of drawbacks of compounding so that we know when not to use it. because that's just as important, if not more important, than when to use it. So one of the main ones is that a drug that's brought to market in the commercial sense, by big pharma and put through the rigors of the FDA's process for getting a medication approved, that involves hundreds of millions of dollars and these very large clinical trials where thousands of patients are exposed in a very controlled way. These are double-blinded, placebo-controlled, randomized trials that are very expensive. But they're very useful for teasing out every possible side effect, the percentages of how often those side effects occur in patients, exact dosing that can be pinned down to very specific methodologies for treating specific indications or specific disease states. That doesn't exist in compounding. So it's not regulated nearly as strictly by the FDA. And along with that comes unknown side effect profiles. Generally speaking, you can use the rule that anything that you take orally, any active ingredient that you take orally, and any side effect that might occur with that medication can generally be a possibility when it's compounded into a different formulation. So that allows you to sort of warn the patient of what could occur. But that doesn't mean that that's everything that could occur, because, for example, if it was a pill that you turned into a cream, now you're putting it into a cream base, and maybe that patient has a rash when they use that particular cream base. So that's an example of a side effect that might occur with compounding that wouldn't have occurred with the commercially available item. So it's a two-way street, though. That can go the other way, where many side effects that might occur with the commercial item won't occur when you compound it into a different formulation. So just be aware that that exists, that separation there exists, and that you might not always know exactly what you're getting into without consulting a pharmacist, consulting a doctor, and getting specific education on that product. Also, drug-drug interaction profiles vary. So these are things that are teased out in these trials, where they take thousands of patients on thousands of different medication regimens, and then they rigorously document any interaction that might have occurred and what the two drugs were and what the reaction was. So when you make a medication, when you compound it into a new formulation or something that hasn't been tested, generally speaking, you can guesstimate that you're going to have many of the same drug-drug interactions, but again, it's not a defined science. This can be beneficial as well as a drawback. For example, if you take two pills that a patient is taking and he swallows both of them, and they're both processed through the liver, which is really common. Many medications are hard on the liver because when they're digested in the stomach or the duodenum or the jejunum, the blood from that area drains directly to the liver, so that the liver can scrub it of these, what they call xenobiotics, these non-natural compounds, before the drug gets into the system. So that's why oftentimes drugs are difficult on the liver, because that's where the blood drains to before it goes into systemic circulation. So if you take one of those drugs and now make it into a topical formulation, then the patient can put it on, rub it in, and instead of going through the liver, it now goes directly into the systemic circulation and bypasses that first pass metabolism, what they call it, in the liver. So now you might not have that drug-drug interaction anymore, because only one of the two is going through the liver. So there's less stress. So that can be a benefit. You have a question?
Can you just review maybe for us what are some of the ways you compound medication? Besides swallowing it, what else do you do?
Oh, we're going to get into that.
Oh, that's okay.
There's lots more. Don't worry. So again, some of the drawbacks is it's not quite as defined. And also I put on there, don't reinvent the wheel. One of the drawbacks is that people find out that they can do this, say if they have a sensitivity, and then they just go to town, they ask their doctor to have everything compounded, and we end up seeing a lot of patients that may be benefiting from the compound, but the benefits sometimes can be questionable compared to traditional therapies, especially when they're so well defined. So there is a place for compounding, but it's not for everything in every situation. So I touched on the New England Compounding Centers of America debacle, where you may have heard they were providing epidurals that were infected with a fungus. And so many patients actually passed away from this This was all their main mistake as well, aside from just egregious protocol errors. They had, for example, fish tanks in their sterile compounding room. Great idea. Is that they weren't tracking where all their doses were going. So when the FDA got caught wind of this happening, they asked them to track down and notify everybody, and they couldn't even do that. So this was a big black eye on the compounding industry, and it actually led to some really positive changes. But it's one of the reasons why a lot of pharmacies won't dabble in sterile compounding, because A, the press is so bad right now, but B, there's also really heightened regulation on it, which is a good thing. So they've invented this board called the Pharmacy Compounding Accreditation Board now. All the major players in the industry got together to sort of standardize things. And so now this is going to, over the next 10 years, become the standard in the industry. It isn't quite there yet, but much like a college or a high school is accredited by a board that determines whether or not they're meeting certain standards, that is what PCAB is going to be moving forward. So if ever you encounter this and you're going to a pharmacy trying to understand if they're reputable, two main questions are going to come into play. Do they do third-party assaying tests, where they take a sample of the random samples of medications they make and send them off to a third party to verify that they are what they say they are? And are they PCAB accredited? We're currently in the process for becoming PCAB accredited. It's a very new thing. There's only a few in the state right now that are pharmacies, but know that that's coming, and that's going to be a really big deal. Also worth noting, we can't reproduce a commercially available product. It's patent infringement, so we can't just do it because we can make it cheaper. We get a lot of those phone calls, but just know that that's there. So the benefits. There's a lot of formulation flexibility. I have a slide here where I'm going to go through many of the common formulations, as Kira touched on, so we'll get good exposure to that. But it's one of the huge perks. We can take something, say if you have a patient with intractable nausea and vomiting, and they're on 17 oral medications that they should take. We see those patients. What do you do, right? What do you do all of a sudden they need all their diabetes medications or what have you? Well, we can take those and we can turn them into suppositories or creams possibly, so that they don't have to swallow anything. And they can still follow their drug regimen and be treated adequately. So that's a major plus. Now this also applies to pediatric patients, but major plus. Also, we deal with a lot of allergy or dietary restrictions, so patients who have sensitivities to dyes, for example. A lot of the big pharma companies print numbers and what have you on their tablets and capsules in dye, and patients who have an allergy to a particular dye oftentimes can't take those. So we can obtain the active ingredient and put it in something as benign as organic brown rice flour in a veggie capsule that's made from pine needles that has no writing on it. So we can accommodate almost anyone with any sensitivity, and I'm sure you've all either experienced that personally or known someone who is very, very sensitive to these kinds of things. So it can be very beneficial to those patients so that they can take their medications without flare-ups. Oftentimes we see gluten-free diets, patients with celiacs and so forth. I mentioned that we could put them, these medications into very benign fillers. We can actually even take a filler from a patient. If they know, we've had somebody bring in organic coconut flour that they get from Trader Joe's, and that's the only thing they can tolerate, and they bring it in and we'll pack their medication in that filler in a very exact way, but we know that way they can tolerate it. So very unique ability to do that. Obviously, you can't call up Pfizer and ask them to reformulate their, their medication. It just doesn't work that way. So, and oftentimes it's cheaper than the alternative. Again, we can't compound something for the purpose of making it cheaper, but it is just an added benefit because a lot of the times you're paying for those big trials, and only 1 in 10 medications that come to market from big pharma actually make it to market. They actually make it into circulation. So that's $500 million maybe they spent on all 10 of these to only get 1 out. So they have to make up for all of that in the price of their medication. That's why sometimes prices are so high. We don't have to do that. So we can make it a lot cheaper a lot of times. Another example of just the kind of flexibility associated with compounding. This is just a small example. I just had this handy on my desk, so I thought I'd scan it for you to see, of just a couple of bases we can put things in. So maybe somebody's using topical testosterone or topical estrogen products that are in a particular cream base, but again, maybe it gives them a rash. So, you know, they're frustrated by that, they don't know what to do, or maybe the dose is slightly off. So we can put that in at different strengths in various different cream bases. I say creams, but really we can do everything from, you know, ointments to water-based gels to topical oils. We actually even dissolve, for example, progesterone in olive oil. And sometimes patients will use that either topically or sublingually, or we actually make olive oil capsules as well. So great flexibility there too. So back to some of the benefits. There's my little plug for Dollar Drug. You know, there's a lot of QA measures in place, though it is an unregulated industry. I did want you to know that it's not just people making things willy-nilly in their garage. We actually have a lab. It's a, you know, very controlled environment under negative pressure and so forth, very highly trained technicians. We send them off to the Professional Compounding Centers of America where they get training on how to do these things. Our pharmacists have been trained. Also, being a PCCA member is kind of a big deal. Right now, with the lack of that PCAB accreditation in place, they're sort of the anchor for the industry. There's a few of them out there, but PCCA is really the big one, the Professional Compounding Centers of America. And it's very expensive to be in their network, but when you are, you can call them, you know, at any time of the day and ask them, say if a doctor wants something made that you've never made at your pharmacy, instead of just guessing how you would do it or just throwing it together assuming that it'll be efficacious, you can actually call them, speak to their on-hand professionals, access their library, their database of formulas, and verify whether or not this is doable, if so, how to do it, and whether or not there are any studies out there to demonstrate that yes, this active ingredient is going to make it, say, across, you know, the epidermis and into the system. So it's a very, very valuable and resource to have, and a very deep well of information that we are able to access. Also, we do independent third-party potency assays. That's a big, big deal. Because if you say there's 120 milligrams of progesterone in this capsule and I give it to you, and there's only 90, and maybe you think it's not working and you transfer it to your other pharmacy and they do potency assays and they decide, well, you weren't being treated adequately with 120, so, you know, we need to bump it up by 20%. All of a sudden you're getting way more progesterone than you need because that pharmacy wasn't doing their due diligence. So this is a very important topic. And if you take nothing else away, and from today's talk, know that you should be looking for third-party potency assays at a pharmacy you're dealing with and a PCAB-accredited pharmacy over the next 10 years. That'll be a big deal. At Dollar, we've got years of experience. I don't know if anyone here has ever spoken to or heard the name Frank Hench. No? He's been around for a long time. We're lucky to have had him there at Dollar. He just retired, but you know, I think he was 74 when he retired. He's been working at Dollar since the inception, and he was, back in 1984, he was doing all the compounds in 4 hours on a Wednesday for the whole week. And needless to say, it's grown quite a bit. We do about 90 compounds a day now, so, and we have an entire team in the lab that's associated to just making those medications. So it's really come a long way. I've got a lot of experience here. And, also, I put a plug in there. We're trusted by a lot of Sonoma County hospices. We work pretty closely with Memorial, Sutter, and also Heartland Hospice. And you know, we've got great experience working with them over the years. So, formulations. As Kira touched on earlier, there is a litany of possibilities out there. Here are some of the common ones that you might see. In the bottom right, there's a couple of pictures of ones that people oftentimes aren't sure what they are. So you may not have heard of a rectal rocket, but it's actually a very effective tool. It's much like a suppository, except its unique shape keeps it in place to deliver medications locally for patients that have anorectal sequelae, patients who have, you know, fissures or hemorrhoids or what have you. And it delivers medication directly to the site so you can use lower concentrations of the drug to treat the condition. So funny name, funny thing, but it's very effective. We can also make medications into lollipop form for kids. A lot of people don't know that, but it is just a hard candy on a stick. They'll never know the difference. It's flavored, but it does have that Trojan horse medication in there. This is an example of a troche. So if you've ever had the candy Now and Later, has anyone ever had a Now and Later? Remember those? All right. It's much like a troche, similar type of consistency. The ones we make at Dollar are smaller than that. It's probably about a quarter of what you see there, but square-shaped. You park them buccally between the teeth and the cheek, and you sort of allow the medication to be absorbed that way, and you can move it around as it dissolves, and it allows absorption in that fashion for people who have difficulty swallowing. Oftentimes, say, cancer patients, they have a lot of disruption of the tissues in the esophagus. They can't swallow well, so this is one way that they can get their medication. Additionally, we do sublingual pellets, which is simply 60% lactose, 40% sucrose. You know, it's just effectively milk sugar and table sugar that's jammed together with the active ingredient in it. You place that under the tongue. It's about the size of a BB, and it'll dissolve very rapidly. Oftentimes this is used for hormone replacement therapy. Patients put it under their tongue at night before they go to bed. It's dissolved right away, and they get their medication in that form. Does anybody have a question on the formulation here that I didn't touch on? Sure.
I just have a question. The big players, the CVS's, the Walgreens, I mean, are they doing their own compounding, or are they contracting with people like yourself? How does that work?
So for a long time they weren't doing compounding. They recently decided to make sort of a pivot to compounding. I know Safeway just opened a large compounding center somewhere in the center of California, I believe, that's servicing the whole state. So they'll take prescriptions, ship them out there, do the compounding, and then ship it back out. So it takes a little bit longer, and it's sort of a newer thing that they're developing, but they did recently set foot into that sort of, into those waters. We'll kind of see how that develops, but it is there, it is in place at the moment.
Do you see it as an opportunity, though, that maybe you work with some of those players and do it for them? Or?
So it is. I mean, it's also a bit of competition, you know, for lack of a better word. But yeah, I mean, it's nice actually just to bring more attention to the industry, actually, if nothing else. Because if they're doing it, then it becomes more an accepted practice, more doctors start to know about it. Do you see what I'm saying? They lobby for compounders. There's a lot of legislation that's being passed recently pertaining to compounding and its regulation and how insurance is covered and so forth. So it's good to have big players like that in the industry sort of paying attention to it and on our side.
I'm curious, how is a subdermal pellet administered?
So it's typically administered with a syringe, but it's not something that we do because it does have to be sterile.
Right.
So I just put it up there for, you know, completion. But you know, there's some discussion as well over how reliable the release is of the medication, but it is commonly used for hormone replacement therapy. It delivers over about 3 months typically. Does that answer your question?
Mm-hmm.
Okay, thank you. So moving on, I wanted to ask another set of questions here. I'm about to show a slide that you'll have to forgive me for it being so busy, but it touches on all the different disease states, or many of them that we see come through our compounding pharmacy on a daily basis. But I'd like you guys to just quickly give a show of hands of how many of you have encountered a patient in your practice, in your career, that has suffered from one of these conditions and had difficulty with you know, the therapies that are available today.
Come on.
Pretty much everybody. And you know, I was asked to kind of relate this to aging, but the point of that first slide about the CDC's you know, publication, and the point about this slide is that more and more a geriatric patient or a senior citizen is just another person like you and I. They suffer from the same conditions, albeit at a possibly higher level than you know, a younger population. But really, it's all the same conditions we all encounter. And because we compound for all these different conditions, it's directly applicable to that population as well. So hopefully, today's discussion has given you a bit more knowledge about what compounding is, when it's possible to use it in your practice, and how it can help someone that you've encountered or will encounter in the future. I thank you for your time, and I welcome your questions. So we'll start start in the back.
Do you take prescriptions from doctors? Do people carry in their prescriptions?
Yes.
To you and you help with them?
They do. Sir?
Are there any other compounding pharmacies in Sonoma County?
So there is one locally. I don't remember. Oh no, G&G, we're in the G&G shopping center. You're thinking of us. But there's Health First, that's the one, sorry. They are located in Windsor, right? So that would be our main competitor in the county. But yeah, we've been holding the seat of the most business in the county for a long time. I believe you were next in the back, ma'am.
Can a person come directly to you with a condition and ask you to formulate something for them, or do they have to go through a doctor?
Well, certainly they can come in and ask for a consultation, and we can discuss, their symptoms and their condition and possible options for treatment. And certainly we can recommend local providers for them to seek out to treat their condition, but we can't, everything we make in our compounding pharmacy, even if technically you could make it over the counter, we require a prescription just to be thorough with documentation. So you would need a prescription from the doctor first. Are there any more questions? Sir.
You would mention people who have like an adverse reaction to, let's say, a dye on a pill.
Right.
And you'd also mention having problems with patent infringement. Is it because of that adverse reaction that you're allowed to formulate?
And the doctor has to document that.
Okay.
You have to say, compounded due to reaction, to dye, or compounded dye-free, something like that.
Okay.
Sam?
Does Kaiser Permanente, they have a big pharmaceutical, do they do compounding there?
I don't think they do much because we get a lot of their patients referred to us for compounding. So I know we've been, sort of taking on that role for them quite a bit, at least it's Yes.
Are there any times that I might just have a prescription and think, oh, I want to know the other ways that I could have this made, and you discuss the benefits of that?
Certainly. Again, I shy away though from taking someone who's being adequately treated with a commercially available product and steering them towards compounding because if they're being adequately treated, then they're comfortably sitting within the pool of data that's available in Western medicine that dictates how they should be treated. And I don't want to sort of knock them out of that because oftentimes what happens is once something makes it in your medical record, once a switch is made, then it's very rare for patients to come back to it. And maybe that was treating you well, and maybe you could go to compounding, but later on, you move to somewhere where there's no compounding available. The doctor might shy away from using that original medication because they saw you transferred off of it for some reason. So I like to think of those kinds of considerations, but certainly we would discuss that with a patient, definitely. In the back.
I'm curious, how do you parse out what the sensitivity is? So often the elderly are on so many medications that are interacting with one another. So, how do you get to that point where you go, oh, it's that dye, when it could have been like 4 or 5?
It's not so often that it works that way, that someone will call in and say this person's having a reaction and we don't know what it is and here's their 17 medications, what do you think? It usually doesn't work that way. When it's a sensitivity to a dye or say to like parabens or some particular compound, the patient always knows when they come to our pharmacy right off the bat. Typically by the time they're an older adult, it's well documented that they're allergic to this particular compound, and they're very vocal about it actually, usually. Most commonly, they're their biggest advocate. That said, the drug-drug interactions are more easy to tease out because there is such good documentation and good data as far as which medications cause which side effects. If you give me a list of medications and you say this patient is having this really debilitating side effect, which medication do you think it is? Odds are I can whittle the list down to 2 or 3 major offenders because oftentimes they're on multiple medications that might cause the same side effects, so it's hard to exactly know. But once you have those 2 or 3, you can play around with, okay, which of the 2 or 3 are there multiple therapy options for? Okay, now we switch to those, and are they still having this effect? Okay, if they are, then maybe it's the final two, you know, that are causing this interaction. So we'll take one of those two and change the formulation. So maybe, as I discussed earlier, it's now transdermal and bypasses the liver. And then we can eliminate that reaction. Does that answer your question?
Yeah, I just wish that happened more often. But yeah.
Yeah, so I mean, I know the patient population we're discussing, many of them are taking upwards of 10 medications. I see them every day in the pharmacy. So if you ever do encounter that, where somebody really has a debilitating you know, drug interaction that's suspected, do call in. You know, your local pharmacist is happy to discuss it with you. We are $1, and if we can identify that, you know, that can be transformative in the care of that patient. So, and it can really improve their quality of life. Sure.
The guy that's taking the 17 medications, and I'm hearing the word compounding, and I'm thinking you can make that into like 2 or 3. Is that, am I missing this?
Well,
you're just figuring other ways to deliver the medications they're having now, but not necessarily combining.
Well, you can combine them. So I didn't delve so much into that because that tends to be what people know the most about compounding. Hence the cartoon at the beginning, but we certainly can. I've seen up to 7 medications in 1 capsule. So I would only recommend that though if somebody's really stable on a medication for a long time and there's a good reason to do that. You know, if say they're absolutely incapable of managing their therapies because there's just so many pills that require so many different, you know, timings throughout the day, that might be an example of when you might cross that bridge. But again, you know, it's one of those things that we can do. But it's not the goal per se.
Think of this as combining medication.
Right. I don't want everyone to go back and say, "Oh, my patients are on lots of meds. I'll call $1 and we'll just get them all taking 1 pill." Because it's not that simple. It really isn't. But you know, certainly there's a place and a time when that can be appropriate. But it's possible, but it's rare, to be honest, where that's really appropriate. Sir?
My experience as a former pharmaceutical rep and calling on doctors, there's a whole gamut of docs that do keep up with the reading, others that don't, okay? And it's a scary spectrum.
Right.
When they first come out of school, they have a cadre of about 30 different drugs that they use on a regular basis. A lot of them don't see pharmaceutical reps keep up as well. And it's, like I said, it's really a scary situation. A lot of times they don't understand the drug interactions. They don't understand the side effects unless a patient tells them. So I just want to share that with you as a former pharmaceutical rep, calling on cardiologists all the way on down to the family practice.
Right. I mean, there really is a spectrum out there.
So consult your pharmacist, that's the bottom line, okay?
And please steer people to using one pharmacy and as few doctors as they can.
Amen.
Because the more we can sort of rein them into a select group of people managing their care, the better cared for they'll be. Because really, these drug interactions occur, and I see it every day. I would say at least twice a day. At least twice a day I contact doctors because I don't think that they know that this other doctor prescribed drug X that's interacting with drug Y that they're prescribing that might end up killing a patient. It could be a life-threatening, and this is twice a day, you know, every day. So, you know, luckily we have these incredibly powerful computer systems now that can run every possible interaction that's out there. Sometimes it can be pretty annoying, to be honest, because there's thousands of them, and as a pharmacist you have to judge exactly what's dangerous, what's not, when to intervene, when to call the doctor and all this. But it's a fantastic capability that we have nowadays, so the more you can keep somebody at one pharmacy, the better, because then we can put their medication regimen through these algorithms and analyze whether or not there needs to be intervention.
Do you know of a compounding pharmacy in Helena?
I do not.
I didn't.
I know that there's one in San Francisco, and there's another one in Eureka. I know it's really far away. There's a veterinary compounding pharmacy in San Rafael. But there's not a lot of us. There's not a lot of us out there actually, and that's why we're trying to raise awareness, and so that's why I appreciate the opportunity to come out here. Final question in the back, man.
Good, thank you. I wanted to give you the opportunity to talk about the future of drugs, pharmaceutically speaking, and the new developments of compounding everybody's medication based on DNA and other tests that are brand new, so that at some point in the future, all of our medications would be compounded specifically for us as individuals.
Well, that's an exciting possibility. That might be a little further out than, I mean, that might be something I might see at the end of my career, for example. I don't know. It's an exciting possibility that's certainly there. I think what's more likely to happen sooner rather than later is when genetic testing becomes, very, very affordable. Depending on how insurance companies play into this whole discussion. People might receive their genetic code on a credit card when they're born, and then pharmaceutical companies can start parsing out which side effects occur because of which genes. And then at that point, they could provide, say, 3 different versions of the same medication at the same dose, but one might react with one set of genetics better than the other. And just by knowing your genetic code, you can get the right version of drug X, so you won't have side effect Y. I think that's coming pretty soon. We did a lot of discussion about that in pharmacy school, actually. It's called pharmacogenomics, the subject. So thank you for bringing that up. That's definitely in the near future. I think also genetics is going to allow for pharmaceutical companies to come up with more cures than we've seen in the past. Once we can pin things down to a specific gene and turning it on or off, then you can provide a medication that turns it on or off to eliminate a disease. I know my sister actually works for BioMarin in Nevada. It's a pharmaceutical company, and they're actually exploring these kinds of therapies at the moment. So it's a real thing, and this is coming in the near future. So I think that is going to be sooner rather than later, and then the former discussions probably more going to happen maybe 10, 15 years after that. But certainly it's exciting possibility that's out there, and I welcome any breakthroughs that are made in that regard, because it would be transformative for the industry.
Great job.